Thank you everyone for joining us today. My name is Alessa Holler and I'm a program analyst at Healthcare Ready. We greatly appreciate your participation in today's discussion with Dr. Angie Settle and Shayla Leftridge to talk about health equality versus health equity, why knowing the difference matters, which is the third event of a series under the Restoring the Healthcare Workforce for Equity program. We want to make sure this is valuable for you. So this is how we plan to spend the next hour. After our brief opening remarks, we'll dive right into the webinar, followed by a Q&A session. A couple of housekeeping items before we begin. We'll be continuously looking at the chat, so please feel free to post any questions or comments throughout our time together. If you would like to make a verbal remark, please raise your hand so we know to call to you at the end during the Q&A session. The more that you post in the chat and contribute to discussions today, the more beneficial we feel this conversation will be for you all. And it will also help us to adjust and deliver recommendations that are most applicable to your experiences in healthcare settings. I'll now hand it over to my colleague, Angie Im, Healthcare Ready's Associate Director of Programs and Policy.
Hi, and thanks so much, Alessa. For those of you whom we haven't had a chance to meet yet, I'm going to take a moment to briefly introduce Healthcare Ready and our work in health preparedness and response. Healthcare Ready is a nonprofit 501c3. We were founded in the wake of Hurricane Katrina, following the recognition that there needed to be better collaboration and coordination happening between private sector businesses, as well as public sector and the government and emergency response entities, making sure that patients continue to have access to what they need to be healthy or to see a provider to get their medicines and so forth. So today, Healthcare Ready serves as a linkage point, ensuring that necessary conversations are happening between government, businesses, and response entities across health and public health. We're available to support you and healthcare facilities in planning, preparing for, and responding to disasters. We know that, you are all very busy, so thank you for joining us on this hour session today on this very important topic. Today's discussion is brought to you today through our program on restoring the healthcare workforce for equity. It's funded by the Center for Disaster Philanthropy, and it's one of a few initiatives that Healthcare Ready has that is specifically geared towards community health centers and clinics. This program and these webinars that we'll be hosting under the Restoring the Healthcare Workforce for Equity program seek to highlight the challenges the healthcare workforce has experienced before and during COVID, and in our current phase of navigating our recovery. The webinars and research that's being conducted, and there's an invitation for interviews forthcoming at the end of this discussion, are all being conducted with a special emphasis on providing support and resources for communities hit hard by COVID-19. And that includes communities of color, members of the healthcare workforce staff who are also from communities of colors themselves, and all healthcare workers that serve patients in health centers and clinics across the country every day. We hope you'll continue to stay connected and join us for these future webinars and findings for our research on the healthcare workforce. Again, Healthcare Ready is available to you before, during, and after disasters. There's a lot going on, and especially with the devastation that recently hit Hawaii. If you ever need support from us, we're available at alerts@healthcareready.org. Without further ado, I am pleased to pass it off and introduce a great friend to our organization, Ariana Gordillo de Vivero, from the National Association of Free and Charitable Clinics. Pass it off to you, Ariana.
Hi, everybody. Good afternoon, and thank you so much. My name is Ariana Gordillo de Vivero. I am the Director of Strategic Initiatives at the National Association of Free and Charitable Clinics, otherwise known as the NAFC. On behalf of the NAFC, welcome. Just for a little bit of background, I want to share the NAFC is the only a nonprofit 501c3 organization nationally whose mission is solely focused on the issues and the needs of the medically underserved throughout the nation and the more than 1,400 free and charitable clinics that serve them. We work toward a larger mission or a larger vision of a just society that ensures a healthy life and well-being for all by building healthy communities through quality, equitable, and accessible healthcare. Now, I'd like to take a quick moment to thank our friends and partners at Healthcare Ready who are graciously hosting this presentation as part of the Restoring Healthcare Workforce for Equity program. And I couldn't be happier to be able to have our dear friends and colleagues, I'd like emphasis on the friends because they really are, Dr. Angie Settle and Ms. Shayla Leftridge present today on such an important topic for our healthcare workforce. Dr. Angie Settle, a doctorally prepared, board-certified family nurse practitioner, is also the CEO of West Virginia Health Right, West Virginia's oldest and largest free and charitable clinic, serving 43,000 low-income, uninsured, and underinsured West Virginians each year. Dr. Settle has 26 years of experience at a free clinic. West Virginia Health Right also recently opened their Community Wellness Center with a focus on inclusive care in their community's most diverse neighborhood. We also have with us Shayla Leftridge, who is the Community Outreach, DEI Manager, and Wellness Center Site Coordinator, who joined West Virginia Health Right in 2021. Ms. Leftridge holds a Master of Public Administration with an emphasis on nonprofit management, budgets and policy, research methods, and statistical analysis. She also holds a bachelor's degree in business management with a focus in economics and strategic planning. She received a certificate in fostering diversity and inclusion from the Yale School of Management. Ms. Leftridge has been very active in community advocacy and was honored with a Hometown Hero Award in 2016 for her volunteer work. Her goal is to continue to create inclusive and equitable programs that support the local community and encourage community health. Being able to support you all in our shared drive toward health equity is essential to us all. We are very grateful for the work that you do every single day for your communities. So with that, I'm delighted to hand the reins over to Dr. Settle and Ms. Leftridge.
Hey, welcome. We're happy to be here today and to present to you guys. And I want you to know that this has been a huge learning curve for all of us. And I really appreciate Shayla. I can tell you a little bit about how we connected was during COVID. We were doing a lot of COVID outreach and she was doing some volunteer work. And then there was an opportunity to bring her on as a DI manager, and we did that. And if you've ever worked with free clinics, when you come to a free clinic, you have to wear a lot of hats. So she has like 42 titles now that she's proud to wear, including like chef in the wellness center, but enough about that. But we'll get started. Again, I'm Angie Settle. This is something I'm very passionate about. Shayla and I are both passionate about, and we're happy to be here today. I'm gonna let her get started.
Well, again, welcome. And I'm so glad that you guys are here today. We are going to start with the basics because we want to make sure everybody's on the same page. We have a couple of polls we want to show you. If you guys could launch those polls, just so that you can kind of see how you do.
Yeah. So number one, I just want to see what you think. According to a 2020 poll, what percentage of African Americans report being treated unfairly by the healthcare system?
A little bit of time to answer that. Again, these are reports, so they can somewhat be off because everyone isn't always comfortable even answering that question.
We have about 14 more people. We'll give you a second to respond and then we'll close it. Anybody else? Okay. So you all did pretty good. It is correct, 70%. When I first read that, I was shocked. That means out of 10 people, only 3 people felt like they had been treated fairly by the healthcare system. Go ahead and do the next poll.
Okay, so the next poll is what percentage of African Americans report that they do not trust the healthcare system? Go ahead and answer when you can. Similar question, but not the same. We'll give everybody a chance to answer. Okay, you guys did really good on this one as well. So the answer is 55%. So more than half of African Americans say that they don't trust the healthcare system. So that's really important to keep in mind as we're going through this, because this is what we want to address. If you don't trust and you feel like you've been treated unfairly, you're going to be less likely to have a good experience the next time, because you're already going into it with the frame of mind that the people are not there to help you. And as you know, a lot of the way that we get the right answer is by asking the right questions and then them trusting to give you a correct answer. So if you ask me something and I don't feel comfortable telling you, the doctor or nurse is going to have a hard time treating you. So that's going to be a really important thing to address. Okay. So I want to start with the difference between equality and equity. I put a little cartoon here that makes it really easy to see. And you think that everybody knows the answer to this, but they do not. Equality is sameness and equity is fairness. So I always like to use the example of, say, breast cancer. We start screening for breast cancer around age 40, and most insurance companies will give you a mammogram for free at age 40. However, African-American women are more likely to present younger, as early as 25, and they present with a more deadly form of breast cancer. So because of this, by the time we start screening, they not only are more progressed in their disease, but they also have a more deadly form of breast cancer. And so because of that, the mortality rate is quite a bit higher. So it is equality to also let them begin to test at 40, but it's not equitable because they have different needs. They need to be at times tested earlier. So that is the difference between what would be equality and equity.
And also too, I want to comment, a lot of the standards of care that we use in healthcare are predominantly based on findings in Caucasian people. So we need to remember that.
Yeah, some of the research that was done is antiquated and needs to be updated with a wider range of people so that it can be more fair. So when we're talking about diversity, what does that mean? A lot of times people will think of one thing. So if you're in an area like we're in West Virginia and there's not a lot of different races here, so we think of black and white, but diversity is so much wider than that. So I just listed a few things that it can refer to: race, ethnicity, gender, age, sexual orientation, religion, political beliefs, education, physical abilities, socioeconomic background, language, and culture. And I'm sure you can think of more. It is really important to look at all the things that could be considered diversity, because you will have to think of a plan to address each one.
I'm excited, sorry.
Angie's very excited. Okay, tell them a little bit about.
So this is a painful process, okay? Because like I said, I've been with free clinics, 20 some years. And, we just added a diversity, equity, inclusion person about 3 years back. And that was not because of lack of desire. Part of it was funding. But, I'm thinking, hey, we're with it. We're diverse. We're getting it. We're doing all this stuff right. And part of it we were. But when you do a really, bones deep down dig and do a full assessment, not only of your beliefs, those of your staff, those of your clinic, how diverse is your board, how diverse are your policies and procedures, and all of that, it's very, very important that you take a hard look with your binoculars on and you can see. And Shayla's been instrumental in that. Part of that, just coming up to this, I've always felt like I was inclusive, and she was my safe person historically that I would ask questions to. And I think I can say this as a Snow White girl, I would ask her a lot of questions about the culture and things that I didn't understand. And she knew that my heart was pure and I wanted to learn, and she would share that with me. So she and I have that dialogue. It's important that you have that person you have that dialogue with, that you are willing to learn from and that you can take a real hard look at.
And be willing to then listen to that, because it is hurtful. I mean, and it's not just Caucasian people, it's everybody, because bias is something that you have to address first. So what is bias? I mean, bias is, a lot of people think is the big bad wolf. It's this awful, terrible thing. But let me tell you, bias is actually a very natural human reaction. It is very important to realize that bias is something that anybody can develop over time. There's nothing wrong with developing bias. There is something wrong with treating people differently because of it. So taking that self-assessment and saying, oh my gosh, I shouldn't be feeling this way. How can I address that? How can I combat that within myself? And then you can look at how some of your policies might be biased. So you have to be fair to yourself. You have to be fair with the workplace and really identifying potential biases and then addressing them. And then you need to look at your surroundings, figure out what demographics have needs for equitable care. Now, where we live, we may not have a lot of people from a certain country. Maybe we don't have a lot of people from France. So maybe we don't have to focus as much on the specific needs of the French people. But look at your own demographics of what you have. Compare the racial demographics and the socioeconomic makeup of where you live, and start looking at what you can address there. Even if you have to ask around, go door to door, talk to local people. We have found a wealth of resource in our local faith-based leaders and community leaders. So you talk to them and you will be able to really learn a lot.
Absolutely. So part of what we developed, which we'll talk about, is this self-assessment. Not only Shayla, but there was door to door, pounding the pavement in the neighborhood, because what we found is a lot of times you think, oh, this neighborhood needs this, or oh, they need that. This is a kind of part of this. But in creating this safe space that we did, we wanted to hear what the neighborhood thought that they wanted as well. So it's also taking a look at that, because you want to hear where they think things are lacking.
Sometimes we will think we know what people need, and actually we don't. There was a lot of things that we had great intention. We said, oh, this would be great to have, and people would want this. And it turned out they didn't want that. We've seen that over and over again with organizations that have the best intention. They get some money and they say, how can we help? Let's go in this neighborhood and build a dog park. People don't want a dog park.
Right.
Maybe the people are still struggling because they're in a food desert. Maybe they need something else. So it's very important to listen.
What I will say is, and I've learned this as well, your intentions might be great, but nothing screams the fact that you're not inclusive than going in and trying to give people what they don't want. That tells everybody that you have no touch on reality at all of the neighborhood, or have a pulse on it. So that's something you want to be really careful about. And you always want to support what's already existing. You don't want to go in and put a food pantry across the street from a church. I had to learn this one, that has a food pantry. You're just thinking, oh, more food for the community. No, you want to support what's already there. And that's something we'll talk about that we've done.
So how can we be inclusive? First things first, we got to start with leadership. We have to start with our board and start with our management. Make sure that they are trained and that everybody's on the same page when it comes to diversity and inclusiveness. This can be difficult because you will meet resistance, and we'll talk a little bit about how to combat that. But we need to make sure that everyone has access to training materials, make sure that they're up to date on everything. We have a training that we do for our LGBTQIA+ outreach efforts, and it's called Safe Zone. We do it every year because things change and we don't have to understand why they're changed. All we have to know is we need to do our best to be inclusive and to be respectful of that culture. So we try to get recertified every year with this Safe Zone training, and it's really important to stay up to date on those things. And then when you can, it is definitely important to try to diversify your leadership force when you can. So some of the things you can do for professional development is you can do cultural competency and cross-cultural communication, basic health forms in relevant languages. We just had this issue this weekend. We go to do an outreach. We think we're doing great stuff. And here comes someone who's passed out, has heat stroke. It's a teenager. And I'm like, oh gosh, get her in here. Let's see what's going on. Let's assess what's going on, get the nurse in there. And it turns out the patient and the whole family only speak Spanish. Nobody speaks Spanish but me. So here I am translating into Spanish. And I say to Angie, guess what? We got to get translators because I can't be everywhere. We don't have enough staff that speak Spanish. So when you're interviewing, ask, do you speak any other languages? Does anyone speak sign language? Look at the different cultures you have. Do you have people of, say, Muslim faith? And because those are ways that you're going to be able to reach your patients better. You want to make sure that you're diversifying in all ways. That's age, that's sex, that's gender, that's sexual orientation, religion. Look at all those things as you're hiring, and you'll be able to have a more diverse workforce.
That we've already talked about, the community feedback and input. I'm trying to make sure we're cognizant of time. What time? Tell me again, Alyssa, somebody when we need to stop because we're yackers. We'll get everybody in trouble. We like this topic. Just let me know. Okay, that went backwards. Okay. The hiring process we want to talk about, that has to be very, very intense and calculated and purposeful. When our neighborhood, we wanted to make sure at this community wellness center that we had representation with African-American providers, African-American medical assistants, nurses, et cetera. Our community, I would say, is about what, 18%, 15 to 18% African-American. You have to keep trying. You have to be purposeful. You can't just throw an ad out there and take whoever's coming and then, end up with, 90% Caucasian people. It was very important. Shayla taught me, and I agreed, that when we had children come in, that they would see providers that look like them, talk like them. That was also important, not just beyond the healthcare aspect, but also just, giving them goals for the future. So it was very, very, very important.
And I want to take this moment to answer a question that was sent in to us about overcoming the objection and primary fear of diversity. And the reason why I'm interjecting it here is because you will not just hear these objections from lawmakers or people but you will also hear this from people on your staff. So how do you get them to buy into this? Okay. One of the things you're going to do is you can invite some of those current decision makers into the conversation, because the primary objective that we hear of diversity is, well, if you just hire people based on race or religion or sex, then we're not going to have the quality because we're just choosing them for one reason or the other. That is a valid and legitimate reason, and people need to know that you're listening to that. So it is very good to address that you do hear that and that you are not going to sacrifice quality. So how can you still be diverse and make sure you're maintaining quality? You're definitely going to take your time. You're going to have to work really hard to get candidates. You're going to have to look outside of your area. You may have to mentor and train someone or hire them from within for the job you need them for, because people can be qualified in one way and not the other. So I think that's really important.
And what she's speaking at, and one, is historically marginalized populations maybe have not had equal opportunity to excel or be in a management level role. So part of that may be taking somebody with great potential and mentoring them into that position, working with them. And that's something. An example would be, we had an African-American nurse, great nurse. She was in nurse practitioner school. I knew I needed a nurse practitioner. I needed diversity. I hired her as an RN. She was great. We worked with her until she graduated. She just graduated and now we have her in position. Great find, good strategic planning. You can't always just think about dollars and cents. And right now you got to be ready to mentor. And
the second week that she was a nurse practitioner, one of the patients came over to the wellness center and said, I really appreciate you putting me with Miss Tamika because I trust her. And, I wasn't really sure if this was going to work, but I really trust her and I really like her. So that told me right there that we had made the correct decision.
This second part, make sure all voices are heard and coworkers feel safe. This is something we've had to revisit over and over. You got to make sure you're all rowing in the same direction. Everybody on staff has buy-in. If they don't have buy-in and they don't believe that health equity is an issue, they don't have any sense, they don't have any business being in there. I've had to revisit this issue and remind people while we're there what our main mission is. And if I hear somebody that's not receptive or they're not having buy-in, then they have to be removed.
you will see pushback against DEI initiatives. It's nothing new, but you need to identify why that pushback is happening. Make sure that they know that you hear them. And the best way that we have found to get them on board is not to just tell them this is what you need to do and this is what you need to feel, but you actually need to show them the examples so that they can see for themselves, oh, wow, these people are not getting the same care as everyone else. Let's figure out how to do it. And that's how you're going to gain your buy-in. So definitely you have to listen to the people that you hire. Listen to your staff, even the ones that are not on your team right now, because they're the ones that are going to teach you how to teach them. Okay. So make sure you're recognizing and appreciating all the cultural differences. You know, one thing I do not like to hear, and God knows that a lot of people have the best intentions, but when I hear people say, I don't see color, it's an instant red flag. Okay. We all see color. Otherwise we'd be dressed like clowns.
I had to learn that. See, I used to think that was a good thing to say. Shayla had left for me and said, no, Angie, I know what you mean, but when you say that, that makes us feel, and I'm like, whoa. So that was a good teaching moment for me.
Yeah,
I don't say that ever again.
That everyone sees color. We don't want you to not see our color. We want you to not treat us differently for it. We want to respect and appreciate everyone's differences. And the only way you can do that is if you see the differences. Okay, so be the example, recognize your limitations, and then they will follow you. So there are a lot of benefits to healthcare diversity. I'm not going to read all of these, but just know that studies have already shown that you're going to have better creativity and problem solving, higher employee morale, better care for diverse populations, because you can definitely more easily address the social determinants of health. You're going to have higher employee retention and better results in decision making. And this has been proven over and over and over again that when you diversify, it is absolutely going to help your staff and your patients.
One thing that I've learned a lot, and Shayla's reminded me, so me going into an African-American community, naturally there's going to be resistance because I can't relate. I do not have lived-in experience, but Shayla trusts me. She knows my heart. She's worked with me. Shayla takes me in there. They trust Shayla. Shayla tells everybody, this is Angie. She's good people. You can trust her. And that trust is transferred to me. We have to do that a lot in healthcare, especially on the west side at that center. We'll get people to come to a cooking class or come for something else. We really want them in the clinic. But there's a little bit of mistrust. You saw the beginning questions, but then Shayla tells them, look, you can trust you. I went over there one day just to talk and they were like, oh, you're the CEO, you're over here. You know, I'm there to learn. And then now they trust the organization because I was there and she trusts me. That's a lot to learn.
It is, and that is why also you have to get everybody on your staff on board, because if I'm going to transfer my trust to Angie, I need to trust her first. Right? I can't just send people over there and not know what she's going to do. I trust Angie. So if someone comes in and says they need something and I say, listen, I have somebody I want you to see. Okay. I promise you she's good people. She's going to take care of you. And I'll walk them over there. Now they're going to trust her, or at least give her a shot because I said so. And that might be what you have to do to every single patient, every single one. But I'll give you a real quick example. We're trying to do more testing. We're trying to focus on HIV and Hep C because it's a big issue over here. So a girl goes in and she's a sweet little girl. She goes in and she tells the class, we're going to do HIV and Hep C testing. We're going to add it to all of our classes. She got one person out of 32 to sign up, and she came back very discouraged. And so myself and my nurse educator went over there and we sat and talked to her.
The first person was Caucasian. The next two are African-American.
So we go over there and we talk to them. We got 100% participation. Does that mean the other girl didn't know she was doing? No, but they didn't trust her and they didn't know her. So once we did that, in 3 months, when we were ready to test again, they didn't need us to go with them because we were able to transfer that trust. Everybody knew what was going on. So we want to make sure that we're removing any of the risks of lacking healthcare diversity, because that's one of them. You've got all these people that wouldn't have gotten screened that got screened. So you're looking at communication breakdown, lack of role models, lack of future diversity, bias in healthcare, poor patient care, limited perspectives. So we don't want to miss out on opportunities.
I got to add this in there real quick and then I'm going to be quiet. As a provider, it is very hard to take a look at yourself and ask yourself, but this is a real issue. I'm not going to tell anybody anything because they haven't, but I've had people, very close friends of mine in the hospital had procedures that are African-American and cannot get pain medication. And I've had to call up on the floor and raise all kind of HE-double hockey sticks to get them the care that they needed. And you think, how in the world could that be happening today? And you hear about all of the inequities in terms of women, postpartum and deaths and everything. It's real. I would ask you very first to sit down and recognize it is a real happening event, not in the 60s, not in the 80s, today.
So I put up a couple of examples of disparities in healthcare outcomes by ethnicity. Of course, there's a whole lot of other ways we can look at that. But for example, African-American women with breast cancer, 67% more likely to die than Caucasian women. Indigenous women, 2 times as likely to develop cervical cancer and have a 47% higher mortality rate. And let me just point out, part of that is because 80% of us catching cervical cancer in Indigenous women come from regular screenings. Why don't they like screenings? Anybody know? Let me tell you, because in the 1960s, they made a law that made it, that sterilized up to 40% of Indigenous women in the US without their consent. And once abortion became legal, anyone who was Indigenous that had an abortion, it was mandatory sterilization. So that was just my generation and my parents' generation. It is not surprising that they don't want to get a pap smear, but that is the way you're going to catch cervical cancer. So that is just a really quick example. And the same thing goes for, diabetes for Hispanic and African-American women, and the mortality rate for African-American infants, which is 5 times greater than it is for white children. So these are ways that if we don't address them, we are part of the problem.
Well, and you notice at the bottom, and this is right up our alley, when you look at factors like, income and their insurance, everything, they're even more stigmatized and, are provided even less care. So that's something that we're battling here. Oops. So let me tell you where we were, thinking we were all great. When I became the CEO 9.5 years ago, we had 16,000 patients. We had 1 clinic. We were doing God's work, we thought. We had medical specialty, we had a pharmacy, we had dental. We had probably 30 some staff. We had some diversity, not a lot. But as things move along and we learn and grow, we have to grow with it and we have to respond. So now we have, and we're going to let Shayla talk to you, but we have 3 stationary locations. The main clinic, I shouldn't call it the main, I'm not supposed to do that. Sorry, Rachel. It's the East End Clinic. The East End Clinic. We call it the main sometimes because it has the most dental and everything in it, but it's the East End Clinic. It has the dental and vision and behavioral health and SUD and health ed and all of that in it, and the pharmacy. A second site was added a few years back that is in the most unsheltered area of our community. And we do a lot of service to those with SUD and behavioral health and transient people. And we cater specifically, it's a walk-in clinic. It's small. It's 3 rooms. It's intimate. It's not intimidating. But the biggest thing that we really did was in 2021, we went for it on the west side. It's something we wanted to do for a while. I knew that I wasn't geared for that because I don't have that lived in experience, but together we worked on it with the neighborhood. And I'm going to let Shayla take over and just tell you about the community, Unity, UNITY Wellness Center and what we've done.
So the Community Wellness Center is on the west side of Charleston, West Virginia, which is actually the most diverse neighborhood in the county. It is focused on diversity from the staff to the decor. It seems like you wouldn't think of that, but you want people to come in and feel welcome.
That's Shayla in the middle, ain't she cute?
So one thing we did was we made sure our staff was very diverse. There's all races there. There's all demographics of people because we want everyone that comes in to be able to identify with someone. We made sure that we educated everyone and trained everyone, but this could not be a regular clinic. Clinic was the beginning. Phase 1 of 4.5.
We had 4 phases, and I'm just going to keep it simple. It's all about money. We went, how much money do we have? We finished phase 1, got some more money. How far can we go with that? That was phase 2. Got some more money. Okay, phase 3, and then phase 4 was the end.
So we looked at diversity and health equity and how can we really support our patients the best? It isn't just going to be okay to just give out medicine. That's equality, but it is not equity. So I'll use a diabetic patient, for example. How do we support that? Yes, we're going to give them insulin or metformin or whatever they need, but also they need to learn how to live with diabetes. So we added classrooms and meeting spaces, behavioral health. We added a teaching kitchen, which teaches 4 adult classes a week. It teaches a kids cooking class once a month. It teaches even a children's cooking class for children that are visually impaired or blind. And so this is teaching them how to live. We added a gym so that they learn how to move. We have a personal trainer. We have fitness classes now in our activity room. So it's free, everything free. So now people can take that one diagnosis and learn how to cook, how to move, how to treat their body, how to medicate correctly. And now we have a real health equity. So on top of that, we're also teaching them other things that make them healthy, behavioral health, so that they are mentally healthy. We also are teaching them about financial wellness so that they can learn how to buy a house, how to fix their credit score. We're anyone in the community that has any type of education that is free, that is beneficial to community health, we allow them the space for free, and we offer the classes for free so that people are really learning how to live a healthy lifestyle from top to bottom.
So in the third phase that we added, the second phase was the teaching kitchen, the free gym, a kid care space so that moms and dads can bring their kids and leave them there while they're at the classes, while they're trying to get the educational training, while they're getting a pap smear or whatever. And then the behavioral health space. But then on the third phase, I had this thing in my heart that I wanted to do ballet classes for the kids in the community. I wanted them to have the same experience that my children had about 6 blocks over at a ballet place. So I said, we got to have mirrors. We went to ballet bars, big old, activity room. We'll do the Zumba. We'll support local African-American individuals who teach like hip hop classes and all that. But we got that. So we have, we used some grant money. We got little tutus, little shoes. And you think, why in the world is a free clinic getting into that? Well, it's putting activity in early. But the main thing is it's bringing those mommies and daddies in there. And while they're there watching their kids, that gives us a chance to build that relationship. And the next thing you know, we're checking their A1C, we've got them in the clinic, and they're getting all the care. And then we also did a big space with computers so that we can get people job ready, resume building, mock interviews. There's a career corner where you can get an outfit. It's really, really nice outfit for your interview. Mm-hmm. And then the community office space it's like she said, it's free. Outfitted offices with computers, phone, everything you need to be successful. And we have like a university there. We have people that are helping, like she said, credit scores, jobs, et cetera. But the only thing that we ask is you can't charge for it. You have to add value to the community. So
that's also us hand holding people. So we have our Department of Health and Human Resources has space there. So if people come in and we find out what they're food insecure, or we find out they don't have Medicare, Medicaid, we can walk them over to these offices and walk them over to these community partners and get them hooked up right then. Because as you know, if we say, hey, go downtown to this building and fill out this paperwork, it may or may not happen. But on top of that, we're building those bridges in the community with other partners. But remember, these children that come in, they're learning how to move early. They're learning activity is great outside of the computer and the phone. But also, these are children that are now not afraid of us. They're going to grow up to be adults that are not afraid of us, that are not afraid of healthcare, because they remember Miss Angie and they remember Miss Shay. Remember when I took ballet? And I remember being young the first time I ever saw a Black ballerina thinking, oh my gosh, I didn't know we could even be that. So giving these experiences, is a benefit in a multitude of ways. So we're going to keep thinking of not only ways to connect, but also to remove those barriers of care. We even have a transport vehicle if we have to give rides. So we're trying to think of everything.
The final phase, which I talked to you about, we had a really great partner community, a More Excellent Way Life Center Church right across the street from us. They let us host our opening there when we were telling the community we were coming. We did COVID drive-throughs there. We did a lot of stuff. As I said, I learned they had a great food pantry there, or food distribution center. So early on, I said, Shayla, we got to save a little space in that building. We have got to help get him a space to work his food pantry out of. You got these little ladies, they're working with, the pews, and there's cans stacked up. So I kept saying, don't give up on me. We're going to find somebody. So finally, last spring or this past spring, they were able to open the John 6 Food Center. It's amazing. They didn't have to do anything. We had some grant money. We had them outfitted to a T. And now they support, people in the community and recovery homes. Those women come over, walk over and help do the boxes and everything. But again, there's strategic strategy there because the community trusts Pastor Haley. Now Pastor Haley trusts me. We can piggyback off that, do, blood pressure screenings and hemoglobin A1Cs and all that kind of stuff as attached to their program. And then that's another introductory point into the clinic. And then also we have a source for food insecurities every day now. So if we have a patient with a food insecurity, we can go in there and get a box, and the boxes are specific to whatever disease state. So honestly, it's amazing. You have to see it. It's hard to talk about, but this is a 15,000 square foot building that we started out with like nothing. And in 22 months by just pouring ourselves into it, and she poured herself into it more than anybody, painting and chefry and cooking and doing all that. We were able to outfit, finish an entire 15,000 square foot building with everything that the community had told us that they wanted, every box checked, and a really, 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 really pretty mural on the end of the building that captures what we're doing, which is sowing seeds in the community.
And let me just point this out too, with health equity. We take people who are uninsured or underinsured with Medicare and Medicaid. However, in our wellness center, there are no financial stipulations to utilizing those services. And the way this is equitable is, for example, in our cooking class, I have 2 cooking classes for adults: Stealthy Healthy, where the food is healthy, but it tastes like regular
They got
food.
the cutest names, Stealthy Healthy.
And the other one is called Chop It Like It's Hot. So in these classes, we do also screen. We do a rapid A1C. We do HIV and Hep C screening at the beginning of each 3-month cohort. Well, what do you know? We have people who are who have private insurance but are in these classes because they have not been told a lot of things by their doctor. And doing these screenings, we have been able to find people who are diabetic and did not know it. And so they were able, and by all rights should have been screened. So they were able to take those results back to their private doctor and say, hey, this A1C says that I'm diabetic. What should I do? And now they're on medication and they're learning how to eat. And even if they are not diabetic, they're taking care of their parents or their family members or their children who are. So this is like kind of a secondhand helping, but that's how you make community healthy instead of just individual health.
Where we're going, some of this is probably dated. We have a lot of it here, but major clinic expansion. We're expanding on our East End clinic, doubling the size of it because there's need there as well. We're increasing mobile access sites. One of the things that we do is mobile outreach with HIV testing, Hep C testing. We do a lot of that on the west side, but we're adding multiple places in the county. We're working hard on staff diversity. We have now, as she said, it's part of onboarding. There is mandatory before you see a patient, touch a patient, get out on the floor anywhere, you have to go through the training. And Shayla oversees that. And if there's ever any issue on staff where anybody doesn't feel welcomed or something happens, she's involved with that. We're immediately addressing that. And it's annual training. You don't want to hear from your staff that they didn't know any better. They know better. Make sure you train them, equip them, and then hold people accountable. You must hold people accountable. And then, improved access to care for all. We recently had Gail Manchin, which she's the ARC chairman in Appalachia, come down. And actually the National Drug Czar, I'm gonna pat us on the back for a minute, and that saw this community wellness center and they were blown away. They said they've never seen anything like it in the entire country. Did we know we were doing something innovative when we were doing it? Not really. We were responding, she knew it. We were responding to community need, had our hearts out there, guts on our sleeve, going at it, and then working hard to get the funding and to put it out there. And now we've created something we're very proud of. And the community's proud of it. It is truly a community wellness center. Okay. There's our contact. If we don't hit a question, I know there's questions, and if we've talked too much, because I do that a lot, that's our contact information. We're happy for you to send questions. And so let's say, Angie, what do you want to pose questions? How you want to handle this?
Yeah, first and foremost, thank you so much for such a great discussion and for really highlighting the importance of diversity in healthcare and that equality is not the same as equity. Really appreciate that. We now have about 13 minutes left today, and would really like to kind of open the floor for any questions or comments from the audience. One question I saw in the chat, which I'll just briefly answer regarding this presentation. We'll be sharing the recording and slide deck with all participants following today's session. So no worries, you'll get it. And also would like to flag a discussion in the chat about political pushback, particularly in, I think the state that was referenced was Florida. Welcome any comments, Angie and Shayla, if you have anything you'd like to add.
So we're a nonprofit and we try not to get political, but right is right and wrong is wrong. And once you've seen it, you can't unsee it. So that's my comment, and I'll let Shayla take it.
We are, you can call it whatever you want to. People are triggered by the word. I don't care what you call it. At the end of the day, like she said, we know these things to be fact. We know from the data, we know from the polls, we know from talking to our patients that health equity is needed. But you will come up on people that are not on board. So even though really COVID-19 really showed us the poor quality of care for all the different demographics, still some people are in denial. So one thing that I would suggest is you cannot make people see what you know. The only thing you can do is you have to show them and let them see it for themselves, because that's how you're going to get buy-in. The same way that we're going to treat our employees and make them have buy-in, that's the same way I would respond to anyone who disagrees with health equity. If you don't want to use the word, you can just show them. You can show them statistics. You can introduce them to people who have gone through it. I myself have gone through some issues, have family history of health inequalities. And so you have to make them feel it on a personal level. Sometimes you have to put it into perspective for them, for their own demographic. I mean, we have people here, this is West Virginia. It's a poor state anyway. So we may have someone who is Caucasian, but they're from what we call the hollers. And they have had their own issues. And so you have to put it into a perspective that they can understand from there. And once they say, oh yeah, that's happened to me, then you can say, that's exactly what's happened to this other, insert marginalized group here. So I think that's how you're going to have to deal with it, because politics will politic, and we can't deal with politics in healthcare. We have to deal with saving lives.
Great, thank you for those comments. If anyone else has a question from the audience and would like to speak verbally, please feel free to raise your hand. I think a follow-up
I see some questions. I see some questions in the chat. Why is it important to understand health equity for many different aspects of healthcare, even for those who do not provide patient care? It's so important. It touches every aspect. If you don't get it, if you've never experienced it, you can't relate. A quick little anecdotal story, but that I would have never thought of. Shayla told me about a time, I'm going to share this, I think you're okay with it, that she got on a plane and the pilot was Black and the flight attendants were Black and everybody on the staff was Black, and that she had a breakdown moment and that she cried because she'd never experienced that in her life. Now I'm going to tear up too, because I had never thought of it that way, ever. Had never thought about how that would feel, because I have lived in a white body my whole life. So people need to relate to that. They need to understand that. Another example, my daughter plays travel volleyball, and there was one African-American girl on her team. And Bethany is real shy, my daughter. And she said, Mommy, she doesn't talk much. I took what I learned. I said, Bethany, how do you think it feels to be the only African-American girl on the whole team, and how hard that would be? You need to make an extra effort to connect with her and make her feel welcome. And that's what we need to do. That's how we have to do it as healthcare workers. Everybody, you've got to make that extra effort. You cannot say that it's equitable care if you can't see that. You have to be able to see that. You have to recognize that. Anyway, I'll start preaching. Number 2.
Okay. How do you manage actively and engage with people who are resistant and still insist they don't?
We just talked about that.
Yeah, we
so
touched on that a little bit. It is hard. So there's 3 forms of pushback, and I wrote this down because we have to deal with this with staff as well as from the outside. So the first one is denial. When people are like, that's not a real thing. That doesn't really happen. That's not true. You know, I hear a lot of times like, why are you guys always bringing up slavery? And that was so long ago. So again, education. It can be really short. One thing that I added just recently when I was getting pushback from staff was every Friday we have a really short 15-minute meeting, and 5 of those minutes we do culture corner. And I will talk about, just like I talked about the Indigenous women and how, you know, they need, we need to really work hard to make sure we're being inclusive and understanding with getting them pap smears.
Something simple, guys, and I didn't know
really
any better. I had to learn that you are not supposed to touch the hair of an African-American female. A lot of you probably knew that. When I'm doting on my daughters and I touch their braids and stuff, I had to learn that. I didn't. And I have a doctorate degree
Angie.
and take care of people, and
Don't
I
do that.
didn't know that. I do it as a feeling of like love and, oh, you don't do that. I had to learn that. Here I am, a doctorate prepared nurse practitioner with almost 30 years experience, and I just learned that last year.
Yeah.
So anybody that says that they don't have anything to learn, they need to take a second look.
Yeah. So the second form of pushback that we see is the "this is not my problem" syndrome. This is the one that I was saying where, you know, if I'm a Black woman, maybe, you know, if I'm a straight Black woman, maybe I don't understand the issues with the LGBTQIA+ population. So I say, well, I don't know anything about that. That doesn't bother me. So it must not be a big deal. Well, we have to, again, educate. And the easiest way to make people see that is to put it into perspective for their demographic. So if someone said to me, well, how would you feel if this happened to Black people? And then I say, oh yeah, that wouldn't be right. Well, that's the same way that this group feels. Now I get it. So that's what you have to do for people that are in the disengagement part of pushback. And the last one is derailment. Those are the ones that say, what about all these other problems? Why are we focused on this when we got all these other problems? Well, guess what? The brain is complex. We can focus on more than one thing. And we need to make sure that we are prioritizing the things that are important. If it is something that deals with healthcare, that's always going to be most important because we hold people's lives in our hands. And we need to make sure that we're addressing that. And even if we have to, you know, prioritize and then set up different teams to deal with different things, just like she has someone to deal with DEI, she has someone to deal with pharmacy, she has someone to deal with dental. They're all different problems, but they're all problems and they all need to be addressed.
The last question, do you screen your patients for social determinants of health? I was just texting my clinical manager. There is a tool that we use, and I don't know the name of it, but I will get it. And if you email me, I will give it to you, or I can send it to them to share. But it's a specific tool that we screen all patients for.
And if you have other questions that you think of later, please do write down our contact information. It may take us a while, but we'll absolutely get back to you. As I said before, we give this information out for free. Just whenever we see you, we charge tacos. But otherwise, we will be happy to answer these questions for you as soon as we can. Did good. We didn't go over too much.
We didn't go over too much. We are very passionate. I'm very passionate about healthcare, very passionate about free clinics, very passionate about this topic. I don't know if you can tell, we've invested a lot of time into it, a lot of learning, a lot of, you know, looking at yourself in the mirror moments. But, you know, we're open book. And so if you have any questions or anything we didn't address, you can feel free to email us.
On behalf of Healthcare Ready and NAFC, thank you so much, Angie and Shayla, for your honesty and for sharing your personal experiences on such an important topic. We really appreciate the thoughtful discussion and all of the tips you shared. So I'll kind of just to wrap us up in the last couple of minutes, please join us on August 23rd at 2 p.m. Eastern Standard Time for our next training. Ariana Gordillo de Vivero, Director of Strategic Initiatives at NAFC, will address tangible ideas and tools that leaders may use within their own organizations to promote self-care and well-being. This event is titled Mental Health, Self-Care, and Burnout at Free and Charitable Clinics. We just dropped the registration link in the chat and hope you all can join. Moreover, as we kind of mentioned at the beginning of this session, as part of this program, we are conducting 20 to 30-minute interviews with community health centers, free and charitable clinics, and federally qualified health centers to understand how the healthcare workforce was impacted by the pandemic. These interviews intend to amplify voices like yours to inform solutions and resources to improve the healthcare worker experience. To find out more about this initiative or to participate, please reach out to research@healthcareready.org or give us a call at 202-240-1803. Lastly, on the topic of wanting to hear your valuable thoughts and ideas, please complete the post-survey training, a link we just shared in the chat. Your feedback will help us inform the success of this program. And with that, we hope you have an amazing rest of your Wednesday and week. Thank you all for joining. And again, please feel free to contact our speakers for any follow-up questions.